So first is the scoring of atopic dermatitis. It is a clinical tool used to assess the extent of severity of eczema. So in this area, to determine the extent, the sites affected by eczema are shaded on a drawing of a body. The rule of 9 is used to calculate the area affected as a percentage of the whole body. So if the hands and neck are involved, then it consists of 9%, upper limbs 9% each, lower limbs 18% each, anterior trunk 18%, back 18%, and the genitals of 1%. So the score for each area is added up on the basis of site involvement, and the total area is A, that is which has the maximum possible of 100%. So first we have to calculate the area affected in atopic dermatitis. Then intensity. A representative area of eczema is selected. In this, the intensity of each of the following signs is assessed as none, 0, mild 1, moderate 2, or severe 3. So in this, such features are included such as the intensity of redness, swelling, oozing or crusting, scratch marks, skin thickening, dryness, that is assessed in an area where there is no inflammation. So such points are included to determine the intensity, and the intensity scores are added up, giving together the B value, that is, and the maximum is 18. So the next is the subjective symptoms like itching and sleeplessness are each scored by the patient or relative using a visual analog scale, that is VAS, where 0 is no itch and 10 is the worst imaginable itch. The scores were added to give C value, that is maximum 20. So in this, itching and sleeplessness is given the subjective scale. So the total score in this scoread is A is calculated by A divided by 5 plus 7B divided by 2 plus C. The next scoring system used is EASI, that is, it is a tool used to measure the extent, that is area and severity of atopic eczema, that is eczema area and severity index. It takes a few minutes and experience to calculate it accurately, and it does not include a grade for dryness or scaling. It includes only inflamed areas. So in this, there are 4 body regions: head and neck, trunk, upper limbs, and lower limbs. So head and neck in this face occupies 33%, that is 17% each side. Neck 33% front and back, and scalp 33% of the head and neck. Trunk, including the genitals, front occupies 55% and the back occupies 45%. Upper limbs, each arm constitutes 50% of the upper limbs region, that is front or back is 25%. And lower limb, including buttocks, each leg occupies 45% and buttocks 10%. So the area score is recorded for each of the 4 regions of the body, and the percentage of skin affected is calculated, such as if there are 2 grades, first is the area score and second is the percentage of skin affected by eczema. So if the area score is 0, no active eczema, and the area score is 1 to 9% of the skin is affected by eczema in each area. Then 2, 3, 4, 5, and 6. 6 is 90 to 100% of the skin is affected. That is, the entire region is affected by eczema. The severity score is recorded for each of the 4 regions, and it is the sum of the intensity scores for 4 signs. And the 4 signs are redness, that is erythema, inflammation; thickness, induration, swelling in case of acute eczema; scratching or excoriations; and the 4th is lichenification, that is lined skin, furrowing, rhigo nodules, suggestive of chronic eczema. The average intensity of each sign in each body is assessed as none, 0, mild 1, moderate 2, or severe 3. And 0, 1, 2, 3, that is none, mild, just perceptible, intensity of redness or itching, scratching, moderate, and severe. And the third one, which is not used nowadays, is poem or patient oriented eczema measures related to ask the subjective questions. So in this, the poem scores of the categorized into 5 bands, severity bands. So 0 to 2 is clear, 3 to 7 is mild, 8 to 16 is moderate, 17 to 24 is severe, and more than 24, that is 25 to 28, is very severe atopic eczema. So such classification is very important to determine the severity of atopic dermatitis in order to determine the proper treatment. So the next topic is complications and comorbidities. So the first one is psychosocial aspects. Now itching, distress at the bath time, severe dryness, difficult to going to sleep, which can lead to impairment in the quality of life. Patient sleep disturbance leads to neurocognitive impairment. Teasing because of abnormal skin appearance, such as seen in dirty neck, can lead to social exclusion and negative effects on the image and self-esteem during adolescence. So it has psychosocial aspects. Second is growth delay, can be seen in severe eczema, and therefore periodic monitoring of weight and height of children is important. Third is bacterial infections. As the epidermal skin barrier is lost, and patient is prone to develop eczema and various. So it is also more prone to develop bacterial infection. That is secondary bacterial infection with Staphylococcus and Streptococcus are common. Widespread impetigo may sometimes mimic Kaposi verruciform eruption. An acute vesicular eruption in an atopic person is suggestive of secondary bacterial or viral infection. So such infections are really common in atopic patients. So which viral infections are common? In both acute and in both active and quiescent forms, acute generalized viral infections like herpes simplex virus, that is eczema herpeticum, first to produce clinical picture of Kaposi verruciform eruption. Widespread molluscum contagiosis is more common in atopic child, and HIV infection may aggravate atopic eczema. So herpes is most commonly associated. Now the fifth complication can be ocular abnormalities. Denny Morgan fold, that is fold of skin under the lower eyelids. This change is not specific to atopic eczema. Next is conjunctival irritation, keratoconus, cataract can occur due to a combination of rubbing and use of topical steroids. Both posterior and anterior subcapsular cataracts are common and usually bilateral, and retinal detachment can occur. So this is a picture of periorbital dermatitis classically seen in atopic patients with Denny Morgan eye fold, that is infraorbital crease. And next is the atopic cataract or subcapsular cataract. Next complications can include lymphomas and cartilaginous pseudocyst of external auricle. And but this is most important, that asthma and allergic rhinitis can seen in 30 to 40% of cases, but the age of onset is later than that of the eczema. So such patients develop the characteristics atopic march. The next complication is dry skin, common feature of atopic eczema. It occurs due to increased transepidermal water loss to an abnormal stratum corneum, an abnormal ceramide and sphingosine synthesis. Ichthyosis vulgaris and keratosis pilaris may also be seen in association with this condition. So dry skin is very common in atopic eczema. Okay. So the next part in this topic is investigation and treatment part. So the diagnosis is based on the constellation of clinical features, that is, and what are the investigations which can which we can do are total serum IgE level, specific IgE level, skin prick test, double-blind placebo-controlled food challenge, atopic patch test, and oral food challenge test. So this is a diagram or representation of skin prick test, also known as allergic skin test, in which an allergy skin is exposed to some allergen to find out whether there is allergic reactions to such allergens. So you have to clean the skin with an alcohol, and then the area is marked on the skin and put a drop of allergen besides every mark. And using a lancet, or the technician pricks your skin to allow a tiny amount of solution to enter just below the skin surface. Now you have to wait for minimum 30 minutes, and it checks. Now, if you're allergic to one of the substances, you will develop a red raised itchy bump, a wheal that may look like a mosquito bite. And according to the recording of the result, uh, it is positive, it is indicative of an allergic skin prick test. Now, what is double blind placebo controlled food challenge test? Freeze dry fruit is disguised in gelatin capsules. Identical gelatin capsules contain a placebo, that is glucose powder. Neither the patient nor the supervisor knows the content of the capsules. Positive test is when the food triggers symptoms when the placebo does not. Now the next is atopy patch test, APT. It involves the epicutaneous application of allergens with evaluation of the induced eczematous skin lesions after 48 and 72 hours. It targets the cellular component of the allergic dermatitis. What is the difference between atopic patch test and patch test? What is it? APT and patch test. So, in APT, you have to detect the alloallergens or the food allergens, while as the patch test is only used to detect the cutaneous antigens or allergens. So, APT is used only in atopic patients, whereas patch test is used in any patient with suspected contact allergy. Skin prick test allergens are separately loaded into one patch test chambers and then used for testing. Whereas in patch test, kits with standardized series are available for direct testing. So the last part of today's topic in atopic dermatitis is management. Now the management protocol includes the following points. That is, first we have to control the triggering factors for atopic dermatitis, various environmental triggers. Second is the general care, which is very important. Next is first line therapy, then second line and third line therapy in atopic dermatitis based on the severity. Recent management includes biologics and emerging therapies, then the maintenance therapy and the adjuvant therapy. So the first part is avoidance of triggering factors. So the common food allergens identified are milk and milk products, peanuts, eggs, soy, wheat, seafood, and shellfish. These are the most common triggering food factors. Food restriction is not recommended in patients of atopic dermatitis. A specific food-free diet should only be considered when the allergic to a specific food is identified. So if a patient is found to be allergic to a particular food, it should be avoided. Second is clothing, that is means smooth cotton clothing and loose fitting garments are recommended. Avoid irritating fabrics and fibers like woolen, acrylic, nylon, and cotton is recommended as the best fabric in such patients. Next is sweating. Avoid occupational exposure to high temperature and humidity. Next is the environmental factors like allergens, house dust, mites, pollens, and organic solvent should be avoided as much as possible. Being sensitized to mites in infancy is a marker for developmental asthma. Next triggering factor to be avoided is avoidance of perfumes, personal hygiene, and cosmetic products. Psychological and psychosomatic interventions are helpful in relieving stress. The second management protocol involves the general care, which includes bathing. So in such patients, once daily bathing with a lukewarm water that is 27 to 30 degrees Celsius, which is not too hot and not too cold, for a short period of time, approximately 5 minutes, is recommended, preferably during daytime. So one has to bath with a lukewarm water for short time. And for cleansing, strong scrubbing or rubbing immediately after the bath should be avoided. And use of non-soap cleansers that are neutral to skin pH, that is pH 5.5, hypoallergenic, non-irritant, and fragrance-free recommended for atopic dermatitis. So such patients should avoid normal harsh soaps and use ascended bath for bathing or cleansers. The next general care includes education to the patients and parents. It encompasses education regarding the appropriate treatment dose and the application frequency, how to step up or step down the treatment, skin care and bathing, very important. And last is the management of infection. So, apart from avoidance of triggering factors and general care, the next treatment is first line therapy. So in such patients, we have to prescribe oral antihistamines for itch control itching, such as cetirizine or levocetirizine may be used for short term under supervision, where itch of the eczema causes sleep disturbance, especially in children less than 2 years of age. Cetirizine also has a steroid sparing effect. Active scratching can further disturb the skin barrier function, which will worsen the atopic state. Therefore, antihistamine can be used, although their role is limited, to prevent further scratching or itching. Next, use of a systemic and topical antibiotic therapy. So, preventive use of topical antibiotic is not recommended. Short courses of topical and systemic antibiotics should be used only if there is an overt secondary infection. Long-term use is avoided to reduce the risk of bacterial resistance and sensitization. So it should only be used when there is clinically evident secondary bacterial infection, only for a short time. So the next management includes wet wrap therapy or WWT. So this is used for controlling acute flares and recalcitrant atopic disease. Now, what is wet wrap therapy? We have to apply the topical agents to the lesion. Then the skin is covered with a wet inner layer of tubular bandage, uh, followed by a dry outer layer. This wet wrap therapy is maintained from several hours to a day at a time. So after applying the topical cream, it is covered with a wet inner layer and dry outer layer. So Wet trap therapy with diluted corticosteroids or emollients is used in moderate to severe atopic dermatitis. So this is a treatment algorithm for atopic dermatitis. So initially we have to assess the disease history, extent, severity, and the activity of atopic dermatitis, which includes family history, background, and associated conditions like asthma or allergic rhinitis. So in this, we have to classify the disease, whether it is infantile, childhood, or adult phase, whether it is mild, moderate, or severe atopic dermatitis. Then explain the disease to the patient and parent, counseling, behavioral modifications, and setting the goal of therapy. Counsel the patient parents about the general care, hygiene, and avoidance of triggering factors. Then, after this, you have to categorize the disease as mild or moderate atopic dermatitis or severe atopic dermatitis. So, in such patients, what will be the first line therapy in mild to moderate atopic dermatitis? So, the first line therapy is giving emollients and moisturizers and topical corticosteroids. These two are very important because the epidermis skin barrier is lost. So the moisture emollients has to will help in recovering the normal skin. So the potent topical corticosteroids to be avoided in face, genitals, and textures. And beyond 3 weeks, so you have to give to mild to moderate potent topical steroids. Apart from this, tacrolimus or pimecrolimus can be preferred in less than 2 years of age, but more than 2 months, and in face, plexus, and genitals, where we can't give topical steroids for a long time. So, if the patient is started on topicals, and if patient is not relieved completely or it turns to severe atopic dermatitis, so in this we have to add short course of oral corticosteroid, that is for 2 weeks, and taper off the dose of 0.5 milligram per kg per day. So in severe atopic dermatitis, treatment first line therapy includes moisturizer and emollients, topical corticosteroid plus short course of oral steroids. So, apart from this first line therapy, the patient does not respond well to the first line therapy in such patients. So, the second line therapy in atopic dermatitis includes cyclosporin. Cyclosporin is an immunomodulator drug. In children, mainly it will be used in a solution or liquid form. So, according to the weight and the severity of patients, cyclosporin can be used. If patient is not relieved on cyclosporin, then the third line therapy in such atopic dermatitis includes azathioprine, light therapy or phototherapy in the form of UVB radiation, mycophenol mofetil or methotrexate. And if patient is not relieved with such third line therapy also, then last option on the fourth line is biologics such as malizumab and the newer biologics or apremilast. So this is the treatment algorithm, first line, second, third, and fourth line. Apart from this, what is the maintenance therapy for atopic dermatitis, which is very important? You have to give weekend topical steroid, that is 2 days a week. You have to apply on a maintenance basis, and topical tacrolimus ointment, and also maintenance phototherapy can be used. Apart from all such treatment, there is very important adjuvant treatment, that is which has to be followed by the patient, that is avoidance, identification and avoidance of triggering factors, which can be any food, drug, cloth, anything, contacts. Second is use of emollients and moisturizers, including ceramides and shea butters. Third is Syndet cleansers for bathing. Next is oral antihistaminics. Then control of infections like short course of topical or systemic antibiotic or antivirals in eczema, herpeticum cases. Then last is psychosomatic approach to control the stress factor. So two things to be remembered which were included in the presentation, that is atopic triad and atopic march. So the atopic triad is atopic eczema, atopic asthma, and atopic allergies. If patient has all three features, that is atopic asthma, allergy, and atopic eczema or dermatitis, which is known as atopic triad. And what is atopic march? In also known as allergic march, refers to a natural history or typical progression of allergy disease that often begin early in life. Atopic march means patient has atopic eczema, then after some time he develops atopic asthma or atopic allergy, and such progression is known as atopic march. So this is about atopic dermatitis. Thank you so much. Hello everyone, myself Dr. Sagar Makhija, Assistant Professor in Index Medical College. So my today's topic is atopic dermatitis. So in this we will include introduction, various etiopathogenesis of atopic dermatitis, clinical features, multiple scoring system for atopic dermatitis, complications, diagnosis, and treatment part. So the first part is introduction. Atopy is derived from the Greek word known as atopia, meaning out of place or placelessness. Now, what is the definition of atopic dermatitis? It is defined as an itchy, chronic, or chronically relapsing inflammatory condition that often starts in early childhood, usually less than 2 years of age. The rash is characterized by erythema, itchy papules, papulovesicles, occasionally vesicles in infants, which may become excoriated and lichenified and typically has a flexural distribution. So it is of two types, intrinsic or extrinsic. Now dermatitis with a normal IgE levels, that is immunoglobulin E antibodies, is intrinsic atopic allergy. And dermatitis with an increase in total IgE levels is extrinsic atopic eczema. Now, the pathogenesis of atopic dermatitis can be divided into three major categories. The first is epidermal barrier dysfunction. Second is immune dysregulation, that is, T helper 2 cells are central to mediating atopic eczema inflammation, Th2 cells. And third is alteration of the microbiome or microorganisms. Now, among this, the most important factor is epidermal barrier dysfunction. So, each of these above factors can be modulated by genetics. That is, there is filaggrin gene mutation in atopic dermatitis, which forms the epidermal barrier, and environmental factors like temperature, sweating, humidity, contact irritants like wool, soap, smoke, cosmetics, aeroallergens like house dust mite, pollen, human dander, pet dander, foods, emotional stress. Can These all are the aggravating factors for atopic dermatitis. So the pathophysiology is there is a genetic susceptibility, that is filaggrin gene mutation, and environmental factors. This both will cause altered skin function or altered skin barrier. This will result in aberrant skin inflammatory response, which will result in disease that is atopic eczema or dermatitis. So, when there is a positive factor of environmental factors, so elevated serum Ig levels can be demonstrated in 80 to 85% of patients with atopic dermatitis, also known as extensive atopic dermatitis. Now, what are the environmental factors? The first is the climate, like UV radiation, ultraviolet radiation, and the well-established immunosuppressive effect, partly because it facilitates the conversion of skin barrier filaggrin breakdown product, that is trans-urocanic acid, into the immunosuppressive cis-urocanic acid isoform, and is an effective therapy for atopic eczema. So UV radiation causes conversion of filaggrin breakdown, that is trans-urocanic acid into cis-urocanic acid. So in lower outdoor temperatures like in winters, especially in combination with skin irritants, can contribute to disease worsening, whereas indoor climate seems less important. And other factors in climate are humidity, can aggravate atopic, and third is pollen count or pollen winds. The second is urban versus rural living. So risk factors linked to urbanization, differences in hygiene related exposure, that is parasitic, bacterial, viral infections, vaccination, antibiotics, farms, environmental pollution, smoking, allergen, and sensitization. And third is the diet. One third of the children with severe atopic eczema suffer from food allergies. Most common foods are milk, egg, fish, wheat, soy, that is soybeans, and peanuts. So these are the most common foods that can cause allergy or atopic eczema, including non-vegetarian like egg, fish, soybeans, peanuts, and milk. So Western affluent diet is low in that is polyunsaturated fatty acids and rich in N6-PUFA, leads to increased risk of atopic. Fish intake during infancy leads to decreased risk of atopic because it is rich in anti-inflammatory gamma-3 polyunsaturated fatty acids. Food-specific T cells have been cloned from the lesion and blood of patients with atopic dermatitis. Now, fourth environmental factor is breastfeeding and delayed weaning. At least 4 months of excessive breastfeeding helps in allergy prevention due to innate immunity. It delays the development of atopic dermatitis, so it helps. Fifth is allergens, that is pollution and tobacco smoke. Nitric oxide, carbon dioxide, CO, carbon monoxide, house dust mites, animal danders, and pollens. These all will aggravate atopic dermatitis. And severity of atopic dermatitis is correlated with the degree of sensitization to allergens. So these were all the environmental factors which aggravate atopic dermatitis. Now, the most common at the top environmental factors are irritants, that is saliva, soap, detergents, food, clothing, in 0 to 2 years and 2 to 12 years of age. Sweat, scratching, foods like cow milk, eggs, meat, fish, and house dust, mice, or pets. And in the age group of 2 to 12 years and 12 years and above, that in adults, apart from this, there are infections and airborne allergens like grass and tree pollen, animal dander. Stress can aggravate atopic dermatitis. Now, what is hygiene hypothesis? According to the theory, an early childhood infection caused by unhygienic contact with the older siblings confers protection from the development of allergic disease, implying that atopic dermatitis and the other atopic disorders are less common in children growing up and with large number of siblings. Now, mechanism is includes Th1 and Th2 deviation. That is basic hygiene, daycare, farm effect, pets, helminth parasites, childhood infections and vaccinations, antibiotics, and microbes. Now, the second mechanism is immunological mechanism. So, in acute stage, there is T helper cells, that is Th2 related cytokines are increased like interleukin 4 and interleukin 13. Chemokines, thymus and activated regulated chemokine and geotaxin. And in chronic stage of inflammatory response, Th1 cells producing interferon gamma, interleukin 12 are released. Langerhans cells and mast cells are also involved in disease pathogenesis as they express higher affinity, that is, towards IgE receptor that causes antigen presenting cells like Langerhans cells and mast cells to release histamines and cytokines. Interleukin 4 and interleukin 13, which are secreted by Th2 cells, they stimulate fibroblasts to produce periostin, causing keratinocytes to produce thymine lipoprotein, which induces CCL17 production by dendritic cells. Now, what are the clinical features of atopic dermatitis? So, first of all, we will see what is the history in such patients. Majority of patients with atopic eczema will present with symptoms in childhood, that is usually less than 2 years of age, typically between 2 to 6 months of age. So it is most common in age group between 2 to 6 months of age. The cardinal symptom is itching associated with chronic fluctuating rash associated with range of features. So thus itching may cause sleep disturbance, irritability, distress in such children. Aggravating factors are warmth, sweating, bathing, exercise, emotional upset, and woolen clothes worn against the skin. So such factors will aggravate atopic dermatitis in an infant, like excessive sweating, bathing, exercise, and woolen clothes. So the skin is inflamed and painful. So the presentation of atopic dermatitis is like it involves three phases: infantile phase, childhood phase, and adult phase. So in infantile phase, presents from birth to up to 2 years of age. Childhood phase is from 2 to 12 years of age, and adult phase is from 12 years to an adult. So, basis on the basis of location of disease, it is characterized such as in infantile phase, it mainly involves the cheeks, the chin, and the forehead. That is a part of face. The childhood phase, lesions are more common singly in elbows and knee creases, that is cubital and popliteal fossa, flexural areas, the wrist and the ankles. And in the adult phase, it is mainly seen over only on the flexural sides, that is elbow and knee creases, along with lichenification. So this is a very important part of atopic dermatitis where we have to classify the clinical disease in the form of three parts, that is infantile phase, childhood phase, and the adult phase. Now, what is infantile phase? It starts on the face but can occur anywhere on the skin surface, but face is the most common side involved. The diaper area is relatively spread in infantile phase. When child begins to crawl, exposed surfaces like the extensor aspects of the knees and the elbows are most commonly involved, such as knees and elbows are most commonly involved because of friction. And what is the lesion in such cases? There is erythema. There is discrete or confluent edematous papules, which are itchy, intensely itchy, and may become exudative and crusted as a result of rubbing and scratching. So there are multiple well-defined discrete or confluent erythematous papules associated with a few excoriations on such surface. So this is a classical picture of atopic dermatitis in infantile phase, where in the face you can see a classical erythema with papules and scaling and crusting, mainly seen over the cheeks, bit of part over the chin and forehead, and also when the child infant begins to crawl, you can see a bit of erythema and excoriations over the feet and the knees. Now the second phase is childhood phase, that is between 2 to 12 years of age. So the sites involved are elbows and knee flexures, cubital and popliteal fossa, the sides of the neck, wrist, and the ankles. What is the lesion in such phases? There is a mixture of erythema, crusting, excoriation, hyper and hypopigmentation, and body lichenification. Because of chronic itching, there is characteristic thickening or lichenification in such lesions. The sides of the neck may show a striking reticulate pigmentation, referred to as atopic dirty neck appearance. So, because of the involvement of sides of neck and continuously scratching and itching, it can cause a characteristic reticular pigmentation, dirty neck. The erythematous and edematous papules tends to be replaced by lichenification. True eczematous lesion with vesiculation may occur, often in discoid patches. So this is a picture of childhood phase of atopic dermatitis, where you can see erythematous and excoriative lesions over the popliteal fossa, over the extensors. Involvement with nail change is common, and the bottom right photo is of atopic dirty neck, that is reticular pigmentation on the neck with long-standing atopic eczema. Now the third phase is the adult phase in patients more than 12 years of age. The clinical picture is similar to that seen in later childhood. That is mainly on the flexures, that is lichenification especially of the flexures and the hands. Localized patches of atopic eczema can occur on nipples, especially in adolescent and young women. Involvement of vermilion of the lips, that is vermilion border and the adjacent skin can occur. Follicular lichenified papules are frequent feature in blacks and Japanese. Photosensitivity may occur. Distribution on the face, forearms, and back may correlate with areas of maximum thermal sweating. So this is a clinical feature of adult face. So in infant, the lesions are mainly seen in the face and the elbows and the knees. Which in childhood phase, the lesions are seen over the uh, cubital fossa, wrist, popliteal fossa, and the ankles. And in the adult phase, such lesions persist to form more lichenification, remains localized hand eczema can provoke with irritant. There is more contact with the irritants. There can be generalized low-grade eczema, patchy and atopic eczema, and it continues to confine towards the limb flexures, that is cubital and popliteal fossa. Apart from this, lips and other areas can also be involved. So this is the picture of adult phase of atopic dermatitis, where the lesions can be seen over the dorsal aspect of fingers, around the nails, because due to contact with the irritants, and also over the popliteal and cubital fossa. Now, apart from clinical features, what is the diagnosis of atopic dermatitis? So that basis on the basis of history and clinical examination, that is the first diagnosis. So there are three diagnostic criteria for atopic dermatitis. That is Hannafin and Rajka criteria, UK Working Party criteria, and the Millennium criteria. So among this, the most commonly used criteria is the Hannafin and Rajka criteria. So this is the Hannafin and Rajka criteria, where the patient has pruritus, itching. Second is typical eczematous morphology, lesions and age-specific distribution of the lesions. That is face, neck, and the extensor extremities in infants and young children. Flexural lesions at any age, from late childhood to adult. Sparing of groin and axilla and flexor these parts. Chronic or relapsing course. And fourth is personal or family history of atopy or allergy. Now, what is the minor criteria? So this was the major criteria. And what is the minor criteria for atopic dermatitis according to Hannafin and Rajka? So in minor criteria, it requires minimum 3 or more. So it includes xerosis, severe dryness, filaggrin gene deficiency associated conditions like keratosis pilaris, KP, which is mainly seen over the uh, upper arms, outer aspect of upper arms and back. Hyperlinear palms, that is increased linearity of palmar crease, and ichthyosis vulgaris. So it is hand and foot eczema, that is eczema characteristically involving only the hands and feet. Fourth is nipple eczema involving the nipple areas. Fifth is cheilitis, that is involving the that is inflammation of the lips and including the vermilion border. Next is the Denny Morgan folds, that is infraorbital crease seen in such patients. Next is the PTRS alba, or that is scaly hypopigmented white patches seen over the mainly on the face. Next is facial pallor or erythema, and ocular findings in such criteria includes recurrent conjunctivitis, anterior subcapsular cataract, or periorbital darkening. This is very important. Next is perifollicular accentuation, and the last is white dermographism or pale dermographism. So this is the minor criteria included in a Hannafin and Rajka criteria, which is very important. Just a minute. So the course is influenced by triggers like climate, irritants, infections, environmental allergies, and food allergies. So the extremes of temperature, that is winter or summer, low humidity, irritants like wool, rough fabrics, perspiration, detergents and solvents, infections like Staphylococcus aureus, herpes simplex, environmental allergies like dust, mites, pollen, contact allergens, and food allergies. Common allergens are egg more than milk, peanuts, fish, soy, and wheat. So these are the triggering factors as we know. And detection of allergen specific IgE antibody via blood or skin prick test. So the UK refinement of Hannafin and Rajka's diagnostic criteria of atopic dermatitis is that in order to qualify as a case of atopic dermatitis, the child must have an itchy skin condition or a parental report of scratching or rubbing in a child, plus three or more of the following findings: onset below the age of 2 years, history of skin crease involvement, that is cheeks in children under 10 years of age, history of a generally dry skin or xerotic skin, personal history of other atopic disease, that is history of any atopic disease in a first degree relative, and visible fractional involvement or dermatitis, that is dermatitis of the cheeks, of forehead and outer limbs in children under 4 years of age. So this is the Hannafin and Rajka's criteria, where on the left hand side you can see the mandatory criteria, specific Ig antibodies, principal criteria, pruritus, typical morphology and chronic or relapsing course, and the additional or the
For post-paid services, press 2.
related to the eczema, that is cheilitis, nipple eczema, pityriasis alba, facial pallor, orbital darkening, cradle cap or infantile seborrheic dermatitis, or tendency for non-specific hand and foot eczema. Related to the dry skin, that is xerosis, ichthyosis, palmar hyperreality, uh, keratosis pilaris, perifollicular accentuation, itch when sweating, intolerance to wool, extra skin folds like denim organ infraorbital fold, anterior neck folds, auricular agates, and ophthalmological pathology, that is Hartoggy sign, photophobia, and anterior subcapsular cataract. So what is the differential diagnosis of atopic dermatitis? First is scabies. Second is infantile seborrheic dermatitis in first few months of life. Third is contact dermatitis. And other rare disorders which may have an atopic eczema like rash includes hyper IgE syndrome, hyper eosinophilic syndrome, agammaglobulinemia, ataxia telangiectasia, and phenylketonuria. So the classification of severity in atopic dermatitis. So three scoring systems are used for assessing the severity. That is SCORAD, scoring atopic dermatitis, eczema area and severity index, and patient oriented eczema measure. That is POEM. So scoring atopic dermatitis is a clinical tool used to assess the extent and severity of eczema. Dermatologists may use this tool before and after treatment to see the area whether it is effective. To determine
भाई इसको कैंटर भी तो बहुत ज्यादा है। दिखा